Okay, so I just recorded a whole video without recording it. So I'm making 100% sure I just pressed record. I did. Okay, so I'm gonna do half of it now, take a break because, yeah, and we will go from there. So I might do two videos. Okay, so let's just start with where I was last time, and I'm going to share my screen with you, and we're gonna start with the PowerPoint. So with the PowerPoint, we are doing, just a reminder, this is chapter 33, and that has to do basically with the upper GI issues and different things that we're gonna talk about, some bringing in some of the therapeutic measures as far as physical and as well as mental. So we're going to talk about anorexia. Even though it's not in the book, I will talk a little bit about bulimia, nausea, vomiting for sure, different things to help with those that are suffering with anorexia, nausea and vomiting, and kind of some basically stuff that's not in the book because you can all read. Definitely going to hit on some points with obesity and certain surgeries that can help with obesity and different potential issues with having these, gastritis and chronic overproduction of hydrochloric acid in the gastric area. And pathophysiology we've already done. And yep, medications. And then pretty much kind of ending more with the peptic ulcer disease, which is very important, especially because this is mainly about med-surg, because that's what the class is. And peptic ulcer disease is a very, I would say, and this all kind of goes together and can go together, which is why I think they put it in the same chapter. And it can kind of help kind of that, hopefully hone in on that critical thinking and those critical thinking skills. So we're going to start with anorexia, and I think that that's a very common term, and we're all familiar with anorexia. So, but there's different types of anorexia. So there's anorexia where it says right here, lack of appetite, right? And it's in your book as well, so you can read more about it. But when it comes down to it, there can be anorexia just in, I have no appetite, I don't want to eat, just the thought of food makes me sick, right? And when I think of that, I think of potentially patients that might have cancer and they just do not want to eat. That this can be a diagnosis for them. It doesn't always have to be a mental health diagnosis. However, of course, we know that there is a mental health diagnosis of anorexia where it's being done as a restriction of food, and they're different. So understanding that it doesn't mean just because, and also as a side note, it doesn't mean just because somebody's super, 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 super skinny, it doesn't mean that they're anorexic. There's genetics that can play a component. There's many, many, many things. So we can't always just make an assumption. One of the key ways of being able to tell is usually, in my experience at least, is through labs and blood work and nutrition, basically seeing if someone has malnutrition. It doesn't say that on here. I think it says it in the book, but and then just as a side note, because I think it's important just to mention it, for bulimia, normally the individual looks normal weight, if you will. It's more about a control thing of, if they feel maybe their life's out of control and or binging and regarding it and then vomiting it out. So usually normal weight. Sometimes they can go together and it can get complicated, but we won't go there because that's not what this is about. But I did want to mention that. Moving along, nausea and vomiting. So this is basically a mechanism of my favorite word, homeostasis, and making your body basically kind of saving you, if you will. So for example, if you were to ingest a poison, more than likely, what do you think is going to happen? Your body's going to want to get it out, throw up. If you get gastritis, like the flu, right, you're going to throw up because your body's trying to get rid of a virus or a bacteria in your stomach, like food poisoning. If you drink too much alcohol, your liver can only, process alcohol 1 ounce per hour. It's basically, excuse me, trying to save you. So that's the essentials of that. Unfortunately, nausea and vomiting, some people do have, so of course we know like pregnancy, or maybe people get like if they have some issues with their ears, they might feel nauseous. Some people just have hyperemesis, if you know me or have had class with me, you know that I have that. And I actually just yesterday got an actual diagnosis that we think we have. It's called cyclic vomiting syndrome, where when you just get really excited, and I get pretty excited when I'm teaching, so that can happen. Or if you get really upset or anxious or something like that. So, and it's very uncomfortable. It's really, really something that, I mean, nobody likes to throw up. It's not something that's fun. If it's, of course, we all know, because I'm sure everyone in watching this video has thrown up before, we always want to protect the airway. It's hard because you're vomiting and then you're trying to breathe, and it's hard because then it's just this vicious cycle, because then you taste the vomit, it makes you want to vomit more, and and you're just gasping for air. Of course, if this person's in the hospital, we can use suction or whatever we need to do, put them on their side, try to keep them as safe as possible. There are medications to help with nausea, just a couple. Reglan, Zofran is something that's one of my favorites. Reglan doesn't seem to work for me. And as a side note, Zofran, they have like a special ones for people who are pregnant now, because Zofran, it has been linked to birth defects. Of course, IV fluids, if somebody's vomiting and vomiting and vomiting, been there. IV fluids, because you are so dehydrated, you can't even think. All your electrolytes are out. It's awful. It's kind of like with anorexia. Even though there may not be vomiting, you're not getting the electrolyte imbalance can be off. I mean, you could have arrhythmias, not having enough potassium. This can be something very dangerous. And of course, knowing potential things to help prevent more nausea from happening, right? So just as a hint or side note that can happen or be helpful is sipping ice water can help. And a lot of people don't know that Benadryl does have a mechanism that can help with nausea. It's an off-label use, but it can help with nausea if you don't have anything else at home. Of course, it will make you tired, but it can help because it has to do with histamine receptors as well. Okay, moving along here, we just talked about both of these things as far as they can be nursing diagnoses. Obesity is something, as we know, is an epidemic in our society. And when I'm talking about obesity, I'm more going to be talking, no matter what the slide says, because we're talking about surgery. So we don't do, or hopefully, at least as far as I'm concerned, what I know, we don't do gastric bypass on someone that's 200 pounds, right? I mean, we're talking about, if you haven't seen the show My 600-Pound Life, that would be something that I would consider you going on YouTube and typing in and watching it. I probably will put a link. I know most of us don't have time, but it is something that's pretty eye-opening. And being that obese is something that you can't hide. I mean, you can hide at home, but you can't hide. It's on your body. You can see it. It is considered an addiction. It is in the DSM-5, which is considered, you can be a food addict, just like you can be a heroin addict or an alcoholic or whatever you want to call it. Any of those things that produce dopamine in the reward pathway, if you've taken psych, which you all have. And, you know, it can be really, really difficult. And just like with any addiction and many different diagnoses, and just kind of having that shame and digging that hole deeper and deeper and feeling so alone. And it can be very, very, really sad and very concerning for the healthcare provider as well, because we have these comorbidities of, I mean, we can take off years and years and years of people's lives due to obesity. I mean, just being overweight could be, potentially 5 to 10 years off your life. Being obese can take off 20 years of your life. And that's not something we, of course, want for our patients, and I'm sure their families and the person themselves as well. I think we're pretty familiar with heart disease and hypertension and the vascular disease. Sleep apnea can especially happen because there's more tissue around the neck. So it's harder to get air in, especially when we're sleeping. So there's a lot of snoring. Type 2 diabetes, definitely. We have that resistance of being able to get our glucose into our, from our bloodstream into I'm totally drawing a blank. I'm sorry. You know what I'm talking about. And then depression, of course. I mean, it can be very lonely, right? And it's one thing to tell someone, well, just stop eating, or don't do this, or don't do that. Well, if anyone, I mean, eating is fun. It's social. It's something that we've become accustomed to just in our society. Well, imagine it being a part of a disease, right? And to make it quick and not too extensive, because I will, of course, it's addiction, I'll go way off and talk about it forever, is basically I mean, the very shortest way of saying it is in our frontal lobe, this is where we critically think, where our impulsivity is, where we make good decisions. And eventually, if we are prone to addiction, or let's say we end up having a food addiction, and that's when usually we'll have like the gastric bypass will come in. You have to have that diagnosis. You have to have, it's not just you go and get it done. It's a big ordeal. It's not just, oh, I want to be skinny, let's do this. In our frontal lobe, they've done studies and have actually seen them next to, let's say, like someone who is a cocaine addict versus somebody who's obese. And they're both lacking dopamine receptors in their frontal lobe, meaning they're lacking dopamine in that area. And if you lack dopamine in your frontal lobe, you have trouble making those decisions and being able to make good decisions. And that's a part of the addiction cycle. I don't want to get too out of control, but basically, big picture, in the place where addiction lives in your brain, if dopamine, which causes reinforcement of behavior, is released, that means it can be addictive. Sex, food, heroin, alcohol, all of these things. So food can be an addiction. If you're seeing what this is, I had a wound, and Andra dressed it for me today, and Chanel yesterday, and I think I forget the third person. I feel bad, but they did a very good job. I burnt myself making soup. Okay, moving along, and then I have an appointment, so I'll probably stop this video, start getting it uploaded so that I can upload it and then make the second part when I get home. So there's definitely more counseling that's done, which I think is extremely important. It's like giving somebody medication for, oh, you crave alcohol? Okay, well, here's medication that's going to help with that, and bye. There's no therapy done. There's no groups done. There's no rehab. What's the underlying stuff going on? There's usually an underlying reason why people are struggling with addiction or depression or whatever it is that's happening. So it's more than just one solution, or hey, let's cut half your stomach out and that's gonna fix everything. Well, is it? Because that, I mean, and remember, your stomach's a muscle, so it can grow back to that big size. And that's why a lot of the time these surgeries don't work, because it's a wham bam thank you ma'am kind of thing, right? Not a let's actually get to the root of the problem and make it a lifelong change. And that's, in my opinion, can be very, very frustrating, because I've seen it, as well as I've seen these things here. So restriction. So of course, it's, like I said, making the stomach smaller, how much you can actually fit in your stomach. Okay, great, that's fine. But if I'm used to eating a certain amount and that's my coping mechanism, do you think that's going to be hard? Yeah, it's going to be hard. And I'm going to need to work through that. And more than likely, maybe not by myself. I might need a support group, Jenny Craig, I don't know, a life coach, a therapist, maybe go to rehab. There are rehabs for people with, this is called a process addiction. So there's chemical, which are substances, and then process addiction, like gaming, masturbation, sex addiction, food addiction. So it is considered an actual diagnosis. Malabsorption, of course, if we need to relearn how to eat. If we're having a surgery done, definitely we want to have some sort of nutritionist, or I did this in the last video that I messed up on, but there's someone else I can't remember the name of that can be in on the team that can help with making sure that someone's getting the proper nutrition. It's just like if you become vegan or vegetarian, and making sure that you're getting what you need because you're taking out something like the most common would be iron, right? But yeah, we just talked about that. So making sure you're not getting malabsorbed. That doesn't make sense, but I think you get what I mean. These are some of the surgeries that we're talking about. I mean, I don't really think it's that important for you to understand each and every one and memorize what do they do to this and that. Just knowing that there's different types, and I'll show you the picture here. There's different types and there's, and different ways. They have some stapling here. They have basically, most of them either bypass your stomach completely, so it doesn't even go in your stomach, or it makes your stomach smaller, or it just all of these different ways of basically making it to where you get fuller quicker so that you hopefully won't overeat. So that's the hope. A lot of complications that I've seen with these surgeries, because I watch that show a lot, because addiction's my thing, right? So I'm very curious and interested, and I try to keep up with the research and the data. Vomiting, of course, because your stomach, it's trauma. It's like any other surgery, it's going to have trauma to it, and being able to really notice things that potentially could not be normal. So, you know, we don't want, obviously, what if stitches start popping open and peritonitis happens, or, you know, we want to be able to do a lot of education with our patients so that we make sure that they know what to look for so that septic shock doesn't happen, and of course death doesn't happen. Right after having a surgery like this, usually food, it takes usually about a month. So we start with liquids, of course, and thicker, and maybe some jello, and then puree foods, and then we can start slowly eating. So a patient can be in the hospital, it depends where you live, of course, but for a week even, or longer, depending on where you are. Point here basically is that you can't just go from having the surgery to the next day eating a steak. Your stomach is it's not gonna be a pretty sight. You'll throw it up. And a lot of people will start throwing up the first couple times they eat because it's just different. And learning how to, as we say, like, our eyes are bigger than our stomach. If I'm used to eating, if I'm, you know, have this specific sort of appetite and this is what I'm used to, it's going to be very, very different having a plate like this and now my plate is like this. It's very, very different. It's a big lifestyle change, right? So that's mental health as well. I think really the only important thing here is, of course, is just, I mean, antibiotics are given prophylactically to help, and we of course want to make sure that we're taking good care of our oral hygiene, so that there's no potential infection that goes either way. As we learned in chapter 32, everything's connected from, you know, your mouth to your anus. So we want to make sure that everything is kept clean and taken good care of. One thing that's interesting, and I mentioned this first from in the last video, has to do with canker sores. So and it's interesting that they put this, because they'll compare them, because I think it's important to understand the difference, because I think a lot of people do get these confused. So a canker sore is literally an ulcer in your mucosa, anywhere in the lining of either your gums, in your esophagus. You can even get them. I get them in my mouth all the time because I love spicy food and I'm very acidic just in general. Of course, we know our gastric ulcer as well as duodenal, and that those are all the same thing. They're just in a different place, and obviously maybe a different size, or could potentially be a different size. In your mouth, they're not usually that big, and they're inside, right in here. And that's basically from acidity. It could be from stress, it could be from food, it could be from whatever. Cold sores is a type of herpes, and that's on the outside. And that's not judgment, oh, one's better than the other, this person's, no, it's just the fact of what the diagnosis would be. So, and they can both come on from stress as well. And so cold sores are on the mouth, and that's the same thing that you can get. So this would be herpes type 1. It's a virus. It can stay in your body for years, well, it's there forever, but you don't always have cold sores, as well as type 2, which would be in the genital region. So, okay. And I think I'm going to stop here, and then I'll come back and finish the video, because I have an appointment in 10 minutes and I'm late as usual. Okay, thank you. I will be back.